Good morning, everybody. My name's Kate Adams. I'm a GP in London, and I've been involved in coordinating this session today. And what we're going to do is look at kind of international differences between the role and structure in primary care. And how we're going to do this is we're going to illustrate it with actually one of my patients in London, who's up on the screen now. His name is Dennis Agate, and he's very happy to be here. I told him I was coming to a conference. And he's really housebound, and he has diabetes. And we thought it'd be much more useful for you to get a sense of how this person would be managed in different healthcare systems. What might be the incentives for those systems to look after this patient, the disincentives, just to get you a feel. So the countries we have that are going to talk about this, we have France, because we're in France. We thought it would be important to have how French primary care would manage Dennis. We have America, we have a delegate from the States. We have the UK, England. And we also have an Australian speaker who's not here yet, but we're hoping, I spoke to him yesterday and he should be here. So that's what we plan to do. So each speaker is going to have 15 minutes, and then we're going to have time for some questions and answers, just for points of clarification about what the speaker. And then we thought we'd have a discussion at the end, if that's all right. So Andrew's here. Hi, Andrew. So I'm very relieved as the chairman that our Australian speaker's now here. So what I've got is I went to visit Dennis at home. Probably about 2 weeks ago I took this photograph, and he lives alone, and I recorded him. So you can hear from Dennis a bit about his healthcare. So I'm just going to play this. So it's 90 seconds. He's actually got a Scottish accent, so it might be quite difficult to tune into him, but let's hope you can hear from Dennis about him.
My name is Dennis Agate. I'm 79 years of age. I was born in London. I retired 58, I think. I owned an off licence, and I went bankrupt. I've got diabetes. I've had my right big toe amputated, and I do get pains. I get pains in both my feet, terrible pains sometimes. I can hardly walk now. I go out in a wheelchair if I do go out. I live alone. I live in a flat. The lift's not working. No chance of me getting out. I've got a lady who comes in 6 days a week for 2 or 3 hours, and she looks after me, does my washing, my cooking, my shopping and laundry and all that. I go to the foot clinic once every 4 weeks now. I've got a catheter bag on, and I've got a nurse comes in once a week to change the bag. The GP surgery looks after my diabetes. I do occasionally get a heart nurse round. I've been in hospital in the past year about four times, maybe 5. Most of it, if I fall down in the house, I can't get up. One other reason was I couldn't breathe. And the last time I was only in for about 3 days was I had an infection in my bladder and my bowels.
So that's Dennis just talking about some of the health problems that he has. I'm going to introduce Bernard Gay, who's our French speaker first, to come up to the podium, and he's going to talk about a patient like Dennis, how he would be managed, and some issues generally in the French healthcare system to do with primary care. Bernard is a GP in rural France, and he's also Professor of General Practice at the University of Bordeaux. Thank you.
Thank you. The first difference for Dennis is what Dennis can see through his windows. I am in Bordeaux, and Bordeaux is famous for its wine, and through his windows, Dennis can see the vineyard of Bordeaux. If Dennis is a new patient for me, he has to be registered in my office. There is no list system in France, but a free choice of doctor. The name is referring doctor, médecin traitant in France, and each patient decides to have this referring doctor for a long time. But if you want to change of doctor, he signs another sheet of paper and he changes of doctor. The goal of this situation is to limit the number of consultations for the same illness, to plan a coordinated consultation procedure for Dennis. In fact, GPs are now gatekeepers. We refer patients to specialists or to secondary care or to hospital when it is necessary, when it can solve the problem of Dennis. The financial incentive is that if Dennis don't choose a referring doctor, he have to pay more than if he have a referring doctor. To follow Dennis' diabetes day to day, I have to go to a visit at home, but if it is possible, I prefer to have a consultation in my office because it's better for the different condition of consultation, material, secretary, and so on. In France, we have 18% of visit and the majority of consultation on office. The mean length of consultation is 18 minutes. A consultation for a chronic disease like diabetes is one each 3 months, but in this particular case, I think that we have a consultation, one consultation each month, and we have a blood test each 3 months for diabetes. Now in France, there is more and more care team with different professionals. For example, in my team, we are 6 GPs, nurses, and physiotherapists, and so on. And in France, the nurses and physiotherapists are on doctor prescription. I have to prescribe different intervention of nurses and of physiotherapists. For Dennis, it's possible to have a home helper to give some help in his house. I have contact also with specialists, endocrinologists and cardiologists, and my task is to coordinate the different workers around Dennis. In my office, I have an electronic personal medical file for Dennis, but there is some problem in France because if is it a home visit, it's difficult to have data for my computer who is in my office. We try in France to experiment telemedicine, but it's very just an experimentation. To manage the problem of Dennis, we try to have some guidelines, and we have two agencies in France. We give recommendation for chronic disease and so on. It's the French National Health Authority and the National Drug Safety Agency. But the problem is that the implementation of this guideline is sometimes difficult for GPs in daily practice. GP side sometimes is not adapted to daily practice, and sometimes it's true because guidelines are based on data from secondary or tertiary situation, and they are not always adapted to primary care. If I have to prescribe some drugs to Dennis have to pay the tablets he takes, but he has a disease, a chronic disease, and public health insurance in France can pay directly the pharmacist. The reimbursement of prescription is in relation of the disease. If Dennis has some chronic disease, it can be reimbursed with 100%. But for the other prescription, we are not in relation with diabetes or heart failure and so on. There is only 70%. Each consultation, I give the quantity of drugs for 1 month. I can prescribe for 3 or 6 months. And there is a strong intervention for prescription of generic drugs, but now for GP is around 20-25% of generic against brands. The re-evaluation of drugs by National Agency of Drugs is in process, and perhaps you know the difficulty we have with drugs. We have some side effect, and it's really a problem now to have safety for drugs. What is the system of payment in France? So I work in Gironde near Dordogne, and as you know, in Dordogne there is many English people. And when English people went to my office for the first time, at the end of the consultation it's really a problem for me, because I have to say, I'm sorry, but in France you have to pay the doctor. In England we don't pay. And sometimes it's difficult to understand, oh, I have to pay the doctor in France? Okay, in France the system is free for service payment. We have to pay to each consultation is 23 euro for a GP. The patient can be reimbursed by public health insurance system. He can have the 30 part can be reimbursed by a complementary optional assurance, but there is a full cover with no more effort if we have two conditions. Universal health coverage based on the principle of solidarity for people who have low income. And the other possibility is a list of 30 diseases with 100 coverage, like diabetes, cancer, heart failure, Alzheimer, and so on. And the way to proceed is to have the green card. It's not the green card like in USA, but it's a card which permits the reimbursement for the patient with a system of teletransmission to the public health insurance. What are the incentives for the primary care physician now? We export from England the P4P, and we try to experiment this possibility. And now we have 29 indicators to have an additional payment for the doctor inside of the fee for service, and a part of P4P of 5 indicators about professional organization, informatization, and some indicators inside the office. 9 about chronic disease, diabetes, high blood pressure, and so on. 8 about prevention, vaccination, screening, and so on. And 7 about efficiency. So efficiency, it's really only a generic prescription. There is no capitation in France because there is an historic process, and trade unions don't like really to have a system, a capitation system. And the consultation rate was negotiated between public health insurance and trade union. Just some picture about financial matter. Health expenses in France are very high, 240,000 millions. It's 12.1 of GDP, and we have the comparison with other countries. And the great part of the expenses are about hospital, and the part of ambulatory setting is lower. One of the problems in France is demography, but it's a problem for French doctors because we have a high number of doctors. It is the number only for GP. This is the number of all GP, and this part of GP we practice in private practice. In France, we have 47% of GP and 53 specialists. There is a process to have a balance of 50-50, but now it's not, again. on average, the density is 1.4 for 1,000 inhabitants, and the average age is very old because it's 43 for the men. And as you see on this picture, the doctors are in blue in the south of France and not in the north. What are the challenges now for the GP? Is to implement primary care as a key of healthcare system, because in France it is a system which is very centered on hospital and not on primary care. The second challenge is to develop evidence-based medicine, but not evidence-based only focused on scientific data, but also focused on clinical context of primary care and also patient preferences. And we have to decide with these three components of the decision, not only with scientific data. The other challenge is to promote European definition of general practice family medicine. You remember this Wonka tree? We show the 12 characteristics of general practice and 6 competencies of GPs. The other challenge is to introduce teaching and learning of general practice in basic medical education, because we have a specific training for general practice, but general practice is not really present during the basic medical education. And the last challenge is to plan continuing professional development, because we discovered this last year in France CPD, and we tried to implement this process. In conclusion, French health system is a good system, because who says that it's a better system, but it's not really efficient, and we have a big deficit, and we have 2 problems. Disparity of care access are growing, and demography is, in some regions, is really deficient, and we need young doctors to follow Dennis. Thank you.
Thank you, Bernard. Are there any questions of clarification about the French healthcare system? Yeah. Can I have this?
Thank you. It said 18% of the care is in the home?
18, yes.
So that means every day you go to a patient's home, like Dennis' home?
Yes, yes.
Okay. So do you do that beginning of your day, the end of your day?
It's depending of the situation of the doctor. If you are in a rural area like me, it's sometimes more than 18%, sometimes 20 or 25%. But if you are in a city, you have more, less visit at home.
And are you still paid €23 per consultation?
Sorry?
Are you still paid €23 for a consultation for home?
At home, we have €23 and €10 for the fees. Okay.
Thank you.
Is things like physiotherapy and nursing care paid for as well, or would Dennis be exempt for it?
Sorry,
Physiotherapy and nursing care, would Dennis have to pay for it, or?
Yeah. Dennis have a chronic disease. We can permit to don't pay the doctor, and I can be paid directly by public health system. But it's because the 2 conditions. 2 possibilities. If Dennis have a chronic disease like diabetes, he don't have to pay me. And if he have low incomes for universal coverage, health coverage. But these 2 conditions permit to don't pay the doctor. But if you don't have a chronic disease, if you don't have low incomes, you have to pay.
But for physio, he wouldn't have to pay either?
Yeah.
He wouldn't pay for anything?
Yeah.
Okay. I know this question there. I'm just going to move on because we've got another 3 presentations. I'm going to invite Joann Falkenburg, who is she's from the States. She's a family physician in Fremont, California, and she serves as divisional lead for the Fremont Primary Care Division Group.
Bright light. Good morning, everyone. I actually don't have any slides. I was more interested in having just a conversation and an overview. As you can appreciate, the United States is a really vast country with a lot of variation. So I thought I would start by introducing my practice situation, which differs somewhat from the rural situation and smaller solo practices which still exist in the United States. I practice in a multi-specialty group that's been around since the 1930s. We have 1,000 physicians across a 100-mile radius with 26 sites, and we have 400 primary care providers. At the site where I practice, I have 20 family physicians who practice with me, and we have 120 physicians on site. So we have radiology, we have cardiology, endocrinology, we have all the specialists we need, general surgery. This differs from 2 of my sisters who practice in rural America, who are in practice with 2 other practitioners and are still on a paper chart and seeing 30 to 50 patients a day. So I'm speaking from my vantage point with dentists, which is a pretty robust system with a robust electronic health record and a lot of access to specialty. So I just wanted to clarify that up front. I would say in the United States, we're a little bit upside down. We're a little bit struggling with how to approach a patient like Dennis. I would say our group is probably the upper echelon, but not the best in approaching a patient like Dennis. We've had an electronic health record for 12 years. It's very robust. It can create databases for us to reach out to Dennis in terms of reminding him to do his diabetes, reminding me to call him to do his diabetes care. We are not as advanced at the Palo Alto Medical Foundation as they are at a place like Kaiser Permanente, where the system is really designed to approach the patient well. Whether he's seeing his specialist or the allergist or coming to the lab, they actually do really robust outreach to patients. In my group, it still really falls on the primary care team to reach out and to take care of a patient like Dennis. And if he doesn't come into us, it can be hard to identify those patients who aren't actually approaching us and getting registered. I went to L'Hôpital Georges Pompidou on Tuesday, and one of the speakers there talked about the age of 80 is the year of living dangerously, where the amount of care needed increases. And in the States, it's actually probably at about age 55, I would say. Our insurance is very much based, your health insurance is very much based on your employment in the United States. A patient like Dennis would actually be quite fortunate because he would qualify for Medicare in the United States, and that's very good coverage for the most part. It's very portable. You can go state to state. Depending on his financial situation, he would qualify possibly for Medicaid, which is the state supplementary, which would support him in purchasing medications and for things such as skilled nursing if he needed to go into a skilled nursing facility. But the patients that are not quite yet 65 are very dependent on their employment or their partner's employment or their spouse's employment. And a 55-year-old who loses their job and cannot be employed is in a very serious situation in terms of being able to access health care. And that's at about the time in the United States now where we're seeing chronic disease really take off. That's where the diabetes is starting, high cholesterol, some cancers, but my 55-year-olds are actually the ones I worry about the most. So what of Dennis? Dennis, in my system, registration would be pretty straightforward. We have about half of our primary care practices open at any given time. We have excellent access. Our consultations for a short appointment are 20 minutes. For a long visit, such as a physical exam, would be 40 minutes. The time to get in is about 1 to 3 days for a 20-minute visit, and less than 7 days for a 40-minute visit. We've worked very hard to maintain that access. So registration for him would be quite easy, but once he's in the door, all the work comes to me and my medical assistant. So primary care is pretty much the medical assistant who is like a nurse, but not quite as licensed. Medical assistants have had about 18 months of training, and They will take vital signs, they will take histories, but they cannot triage and treat patients. They're basically assisting us in care. And then, of course, I have my partners in my department that are taking care of my patients right now. And then we have a nurse. We have a registered nurse will help care for Dennis, help with education, but we have about 1 nurse per every 6 providers. And our panel sizes, right now our goal for a panel size is about 2,000 patients per provider. That may be a little much, I think, when we actually get there. I'm about half-time. I have about 1,300 patients across the lifespan. So Medicare is good for a lot of things. The reason I said Dennis is lucky is he'll have good coverage for his visits. He will sometimes have copays for medications. As long as we stay on generic, it will be much less expensive for him. He has very good mental health coverage, so psychiatry is well covered in Medicare, and hospice care at the end of life is actually very well covered in Medicare. The downside kind of coincides with the incentives with Medicare. Medicare reimbursement is a very difficult thing for primary care right now. The way that we are paid is calculated on what's called a relative value system, an RVU system. It's kind of a complicated system that takes into account what the practice is, what you're doing in your practice, how much it costs you to deliver the care, and what the malpractice risk is. So each consultation or procedure is assigned an RVU amount, and then Medicare reimburses based on those RVUs. In America, the surgeon who chops off his toe and the cardiologist who does a heart procedure will be paid more RVU-wise than I will be paid to manage his diabetes. And so, unfortunately, in our system, the incentives are really there to be more specialized and to do things to patients than to take care of them and to be with them. I could do a home visit for Dennis because he is homebound. That's the only criteria in the United States is a patient must be homebound to do home visits. But to be honest, I rarely do that unless a patient is on hospice because it is so poorly reimbursed that it's better for me to stay in the office and see 4 or 5 patients instead of taking the time to do a home visit. And then the other thing that we are doing, we are at Silicon Valley. Dennis doesn't strike me as somebody who's probably online a lot, but a lot of what we're doing now is electronic care. All of our patients at PAMP have access to their medical record online. They can e-message their care teams. We will send them lab results usually within the day of them receiving it. We have a very robust health maintenance portion of the record that reminds us when things are due. We try to do things like group medical visits. So when Dennis comes into the office, he could actually come to a group medical appointment where he could see the eye doctor, the foot doctor, and get a consultation with a nutritionist at the same time. And then I'd say the biggest disincentive right now for primary care goes back to the compensation piece. Because of the RVU system, some physicians are salaried, and I think that's a very good system. A lot of physicians are still paid based on that production. So it still comes down to how many patients do you see, how many procedures do you do, and that, unfortunately, is a real disincentive to care for patients with chronic diseases who are very challenging. We do have a P4P model that's very similar. In my group, those monies come into the whole group, so they're shared across all the specialties. But there is that incentive. And I would say our biggest struggle in the next 15 to 20 years will be scarcity. There is not a quota, there is not an incentive for young physicians to go into primary care. They are also not subsidized for their medical education. And so many of them come out with debt, actually, and they're trying to set up a practice. And so that will be, and along with a lot more Dennises and fewer of me, I would say that's our biggest challenge in the next 15 to 20 years. So hopefully that's a helpful overview. Happy to answer any clarifying questions. Yes?
Great presentation, covers the USA very well. You didn't mention home health as well.
Home health, well, home health, at least in our system, home health can be tricky because usually the patient has to come out of the hospital and have a qualifying diagnosis, so they need IV antibiotics, and it's not, I mean, my opinion is it's not very robust. A nurse will go in, see them for a minute, maybe do some vital signs and leave. So the home care situation, from my perspective in the States, is not very robust, and there is not a lot of support for a patient like Dennis that does not have a family or a caretaker close to home. yeah, thank you for helping me clarify that.
Can I ask a question about, do you follow some of these physicians in the States, the primary care physicians, follow their patients into hospital when they're admitted?
Yes. Oh, yeah, absolutely. Yeah. There's still a number of primary care physicians who admit to the hospital and follow the patients through their hospital stay. The difference in our system, I did that. I still have hospital privileges, and I still occasionally admit. We have what's called a hospitalist system now, so our hospital specialists will admit the patients and care for them through the whole stay. The beauty of that system is that's the only job they're doing in the daytime, is taking care of the hospital patients. And because we have a very robust electronic health record, the discharge summary comes back to me, and we have good continuity across the hospital stay. So that has been a change for us. But my sisters, for example, would still follow their patients in rural America through their hospital stay.
Any other questions for Joann? Okay. Well, thank you very much. We're going to have a panel afterwards, so to have a discussion. Thank you very much. Our next presenter is Robert Varnam, who's a GP in inner city Manchester in England, UK.
Thank you very much. The advantage of coming a little further down the running order is you get to note down all the things you forgot to say. And I think one of the interesting things, it would be good to discuss this, is how much you learn about your own system by hearing about other people's. So, for example, one of the questions is about the disincentives, and I always tend to think about the lack of incentives rather than actual disincentives. So I'm hoping to use both my slides and my hastily scribbled notes about all the things I take for granted about my setting. I'm a GP in inner city Manchester in the UK. This is us in the UK. Unlike Joann's situation, we're a tiny country rather than a vast one, but we have perhaps as much variation as in the States as well. And I think kind of cutting ahead, I think variability and variation is one of our biggest challenges, particularly in diseases like diabetes, where the burden is rising, and getting it right matters so much. A little bit of history, setting for people who may not know the UK's NHS system was established in 1948. It's the world's largest state-funded healthcare system, serving a population of about 60 odd million, employs 1.7 million staff, so it's one of the top 4 employers in the world. It provides lifelong care, free at the point of access, to everybody, based on their residency in the country, with the exception of prescriptions, where there is a means testing system, and people who are elderly or on low income get free prescriptions, as do children, but everyone else pays. And there are, as in France, some exceptions to that based on diseases, and one of those exceptions is diabetes. So Dennis is elderly and low income and has diabetes, so he gets all of his care, regardless of its setting, regardless of who's providing it, and all of his medicine he gets free. We have a strong primary care system. It's been part of the NHS since its inception, based on a registered list or registered panel system. So everybody in the country is able to register with one primary care practice. They register with the practice rather than an individual. Most of the population, estimates vary, but all but 1 or 2% of the resident population in the UK are registered with a primary care practice. And primary care serves the role of providing care, but also acting as what we call a gatekeeper to other specialist services. So although you can in an emergency go to a hospital and receive emergency care, you couldn't go directly to a diabetologist or gynecologist, or in most places in the country you can't go directly to allied health professionals, so therapists like psychology or physiotherapy or podiatry. Those are all based on a referral from your primary care practice. Most practices in the UK are group practices. The picture is changing very rapidly at the moment, so any data you find will be out of date. But a reasonable estimate at the moment is that about 90, maybe 80% of practices around the UK are group practices. and that's growing. That's growing quite rapidly. The size of practice varies enormously, but a typical British practice would have about 3 or 4 doctors and 1 or 2 nurses, and would serve a population of between about 5,000 and 8,000 patients on their registered list. My own practice, we have 12 whole-time equivalents, 18 doctors, we have 6 nurses, and 19,000 patients on our panel. Primary care provides the majority of daily work in the NHS. This is the sort of daily contacts with the NHS according to context. So general practice does the majority of the work, but it may not surprise you to learn that it gets the minority of the money. One of the challenges on the horizons is exactly the same as other speakers have said, that our care system is unaffordable. And we will be bankrupt eventually, just like every other country, because we use hospital too much, and hospital costs are rising faster than anyone can keep track of, and rising faster than investment in general practice in the UK. So although we're very proud of our primary care, and although primary care does the bulk of work in the NHS, actually the rate of growth of funding, and the past few years have been seen very generous funding, the rate of growth of funding for primary care has been smaller than the rate of growth for hospital care. We have a single system, and I've been talking about the UK and the NHS as though it was a single system, but there is tremendous variation even in a small country such as ours. The first comes from the fact that increasingly over the past few years we've been working on a smaller regional basis, and we increasingly talk about us being a family of nations. We talk about the nations of Scotland, of Wales, of Northern Ireland and of England, and their systems are diverging, so there's a source of growing variation. There's a variable skill mix within our practices, so I can talk about my practice, I can talk about others I know of, but actually it never ceases to surprise me when I visit another practice and discover they, for example, have their own podiatrist. I would love us to have our own podiatrist. I was recently working in a locality where every practice works with their own patient health trainer. I would kill for a health trainer in our practice, or even to have access to one. But they regard it as normal because they've had it for about 10 years or so. So the variation inside the practice is considerable, and the variation around us is considerable as well. So the way in which specialist diabetes services work, the way they vary their work according to being based in hospital or the community, the routes into and out of, the collaboration between primary care and secondary care is pretty variable. So is the provision of other services like podiatry, dietetics, health trainers. And lastly, the incentives. We have some national incentives based on built on top of a basic capitation system. So I'm paid for a patient just to be registered with me, and then I'm also paid on a pay performance scheme. And then in many localities there are additional incentive schemes, particularly targeting areas of priority. So a lot of people have local incentive schemes for diabetes. In my area we only have one, which is about the use of insulin. But in many other areas they've been much more sophisticated. And so that's another source of considerable variation in the NHS. And so the payment system is relatively straightforward. The big thing I think to talk about is the middle one, the pay performance system. I know in the UK has attracted a lot of international interest and has been the subject of a growing amount of research. It's called Pay for Performance, and its title locally is the Quality and Outcomes Framework. But the majority of what it's talking about is process. And particularly in diabetes, one of the strongest criticisms and concerns about it is that it incentivises pretty basic aspects of processes of care. So we are incentivised for measuring diabetics' blood pressure. We're incentivised for measuring a variety of other blood parameters, HbA1c for example. And we receive some reward for achieving good outcomes on the basis of those, but only some. That's growing. It's getting more outcomes focused, but it's currently quite process oriented. So let's think about Dennis. The landscape for Dennis could look quite complex, although I think it's fair to say that right at the heart of it is the fact that the majority of diabetes care, and certainly for a gentleman like Dennis, in my practice, almost all of his care would be provided by us in the practice. We vary according to whether that's doctor-led or nurse-led. In my practice, it would be nurse-led. That's probably true for about half of British general practices. It's changing. It's getting more nurse-led. We regard ourselves as being at the heart of coordinating these other services. And some of those are easy to coordinate and easy to get access to for Dennis, and some of them are very hard. And the one that I've highlighted in a reddish colour, which is very hard, is social care. So care in Dennis's home is clearly a massively important part of achieving safe and effective good outcomes for him, a good experience for him. And yet actually, although there is good social care across the UK, and in my patch it's very good, they don't work for me, I don't work for them, and we don't work together very well at all. I can refer to them, and I might possibly get communication back from them if there is a terrible crisis. But apart from that, I will know nothing about his package of care unless I ask him. And likewise, his social carers will often not know very much about what I'm doing. We don't share records, we don't work as a team. That is changing in some areas for some types of the highest need patients, but it's only just beginning to change, and it's a major deficiency in what we describe as being a holistic, state-provided social care system. It isn't really that good, as it's certainly not as good as you might assume. There's also, down here I've put in green, hospital-based specialties, and they are, specialist care is predominantly hospital-based in the UK at the moment. There are some patches where that's not true, so some patches where almost all diabetology is done outside hospital. They're the exception to the rule. The relationships between primary and secondary care are another source of problem for us. We don't coordinate terribly well. So while you can move from town to town, city to city in the UK, and your lifelong medical record will travel with you from GP to GP, that's not true of hospitals. While I can share my notes and my records with our practice nurses and dietitians, that's not true with the hospital, and it isn't in most people's localities. And while we are incentivised to do some aspects of good outcomes, hospitals are incentivised by pay for activity. So one of the big disincentives in the system is once a patient gets into specialist care, it's very difficult to get out. It takes a lot of letters, and people get very cross sometimes when you try and do it. So it looks like a primary care oriented system, and much of the time it isn't. It is. But once you start involving some of the specialties at the bottom, coordination gets less good. The drive from primary care gets less clear. And that would definitely be true for Dennis. So some strengths. I think it's good to have universal coverage, good that this man will get free care and free prescriptions. I think it's good to have a care for a man like this driven by a holistically based primary care system. And I think it's fair to say the quality of primary care in the UK is good. Here are some charts showing performance in key chronic diseases over the past 10 years or so in the UK. And our quality is improving. 2004 was the year in which our paper for performance scheme was introduced. Those who are interested in run charts, just to let you know. However, let's stick on this question of quality, move to some weaknesses. I talked about variability. We've recently begun learning from Dartmouth Atlas. We now have a UK atlas of variation, and diabetes is one of the things we track. These on the right are the 9 metrics of care which are measured, and the question is asked, what proportion of patients get all 9 of these done? Now you see these are not great outcomes. They're not things being done brilliantly. They're just very, very basic process measures. How many patients get all 9? This is the map of variation. The variation is staggering, as you see, and the range is perhaps quite terrifying. I care about diabetes, I'm very interested in it. I'm scared by the fact that the majority struggle to get above 60% of doing all of these. And there is a worryingly large number who struggle to get above 20% of their patients who've had all of these 9 things done for them. So there are things to be proud of, and there are some things to be deeply ashamed and deeply worried about, and quality of care, I think, is absolutely at the top of those. Coordination and overlap, I think, is a serious problem which people are beginning to address. There's a big buzzword of integration in the UK at the moment. I'm pleased about that. I think it should help. It's often quite a doctor-dominated system. One of the things which we don't have, which I think particularly the American system can teach us a lot about, is the focus on patient ownership. We have an expectation largely of passive patients, and most of my patients comply with that expectation beautifully. But we don't give control, we don't give information, we don't share decisions very much with people like Dennis. Dennis would be done to a lot in the UK. He wouldn't understand very much, he wouldn't take control, he wouldn't make his own decisions very much. And I say that we don't use patient-reported measures of care either, very much. And our micro-incentivisation, our focus on processes, I think is a massive problem. On the horizon, things are, to some extent, looking up. We're facing the same demographic challenge everyone is, and we've not got the most clear plan for how we're going to address it, to be honest. Focusing a bit more specifically about diabetes care for someone like Dennis, we've got steadily toughening incentives. The bar is being raised for diabetes. We've got a growing outcomes focus on conditions like diabetes, both of which are obviously very good. We're starting to talk about bundling. So one of the reasons why, when you look at all 9 of those measures, performance is so embarrassing, is that we don't bundle those in our incentives. You get paid for each individually. Each of them has a target of 70 or 80 or 90% or higher. But it means that many patients don't have all of them, don't have all of good aspects of good care. That's beginning to be discussed. You may have read in the international health press that we're changing our commissioning system, and the biggest change of it is that primary care practices are going to be accountable for the way local services are designed and shaped and paid for. And that gives us a greater incentive actually to look at outcomes rather than activity. That could be very good for us. And there's a growing focus on moving care out of hospital and giving greater control to patients and their families. That's in its infancy. Some people are doing brilliantly at it, some people aren't. This integration agenda, I think, is a big feature of our future in the next few years in diabetes care. So I hope that's been helpful. Happy to answer any questions where I've not been clear at all.
Thank you very much, Rob. That was a great presentation. Are there any questions, points of clarification on the system that was described? I'm just going to come over.
So even though your system is based on primary care, it seems that all the incentives are going to, or most of the incentives are going to the specialized care. And what is the government is doing about it? It's not going to change the policy? And
I think, first of all, I agree to a large extent with your premise that the incentives are largely in hospital. Certainly the greater degree of money goes to hospital. That's partly just because hospital care is more intensive, so it should cost more. But it's true that the government is doing some things to try and shift it. And the 2 things I think in its armoury, although this isn't by deliberate design, I don't think, are firstly that the primary care incentive scheme is getting more outcomes focused. And the general feeling in primary care is that for people like Dennis, where the issues are overlapping multiple morbidities, actually coordinated care by a single provider like the GP practice is usually more effective as well as more efficient. Actually incentivising us more by outcome helps us probably keep more patients to ourselves. At the moment, for example, as long as our practice measure the things we're incentivised to measure, I could send him to the hospital for them to do all of his adjustment of medication. There's no disincentive for me to do that. I think the other big change is that as GP practices become part of the new commissioners of all healthcare services, actually, ultimately, my practice will be responsible for delivering improved outcomes at reduced cost. So we are going to have to, as the new designers of the local healthcare system, we're going to have to do something about the inefficiencies in our system. And I think probably that's going to have a bigger impact more quickly. It's going to be painful, but I think that's the biggest change.
There's a question at the back. Do you want to? Yeah, if you can project.
Yes. This is a question of workforce. I believe that the training of physicians in the UK, about a third or 30% are geriatricians, and here in the United States we have about less than 1% of our physician population who are geriatricians. Do you think there's an outcome difference as a result of that? Training for?
Great question. I don't know. I don't know if anyone else in the room knows the proportion.
I don't think that percentage is right.
It doesn't feel right to me.
It's too.
One of the interesting things, first of all, I don't think that percentage of 30% is correct. I would estimate it's more than 3%, but perhaps not very, very much more than 3%. And it's falling, and has been falling for a number of years. And one of the directions of travel in UK specialism, perhaps as everywhere in the world, is it's become increasingly micro-specialised. And there is talk at the moment about the need for hospital-based specialist medicine to become more holistic again. And questions about whether that's best achieved through ramping up the numbers of geriatricians again, or whether that's best achieved by keeping the coordination with a holistic primary care physician, but giving them more easy access to subspecialty advice. I think the latter is probably more likely. I'm not sure we can do very much to halt the decline in the prominence of geriatrics in the UK. I know the British Geriatric Society are trying to argue against that. I'm not sure that's going to happen. I think it's more likely it will continue getting specialism more specialised, but re-emphasise the coordinating role with easy access to specialism of primary care.
Yes, one.
What is the percentage of primary care of all physicians in Great Britain?
Oh, that's a great question. It is roughly 50-50. It fluctuates quite quickly, and the figures are slightly difficult to interpret. It may be going up. The Royal College of General Practitioners are pushing hard for a growth in the length of training in general practice. They've just won on that, but also in growth in numbers in general practice. And you can foresee a possibility as this integration agenda grows, where more people who have a specialism will actually not work in a hospital. And I think that might begin possibly blurring some of the distinction we currently have between hospital and out of hospital. But the training, interesting question that you raised in France about training. The training introduces a growing proportion of people to general practice early, so both in undergraduate and postgraduate training.
And also, I think the way it's financially rewarded. I mean, some GPs, there's huge variation on this as well, but we are relatively quite well paid. If you turn the clock back 10, 15 years ago, wasn't necessarily the case. Yeah, that's right. Yeah. And yeah, but dynamics are changing because some of the pressures of working in general practice with more and more care and the performance management and the stress and the pressure is also making people think about their careers and how they might want to work, because it's incredibly intense work as well if you're in an inner city area, for instance.
And some practices are making a loss this year for the first time ever. So since 1948, practice incomes have pretty much gone up every year. And this year, some practices are making a loss. The majority of GPs own their practice. A growing number are salaried, but the majority own it. So Yes, the question about the attraction of primary care is an interesting one.
Okay, going to move on. Thanks very much, Robert. Our final speaker is Andrew Knight, who's a GP in the Blue Mountains, west of Sydney, Australia.
So hi, it's good to be here. Tell you a little bit about Australian general practice. We've got 22 million Australians and we've got 22,000 recognised GPs. And we've had mandatory training of GPs since 1996, so that's almost 20 years. So we're starting to work through the group to have everyone with mandatory family medicine training. There's 7,200 practices, and interestingly, most of them are in private hands run by GPs, but increasingly there's corporate practices. Maybe 10%, I think, of Australian general practices are now corporately owned, and that brings in a whole new dynamic because the purpose is to return value to the shareholder rather than perhaps to have the professional values which we're more used to in private general practice. I actually work in a corporate general practice, in a one up the quality end, we like to think, but it's an interesting experience. Australian general practice is highly computerised now. It was transformed in the late 90s from very low computerisation to well in the high 90% of computerised, running electronic health records, which is good because we're just in the process of switching on the National Electronic Health Record. The switch gets flicked on the 1st of July this year. So that'll be an interesting experience. What actually will be available then, we're waiting to see. And who's going to put the data in, we're waiting to see. We think it's going to be us. They're just starting to tell us that. We run in a fee-for-service system, mainly. The vast majority of our income has come through fee-for-service. There's a few incentives around quality. For instance, immunisation. If you hit a certain target in immunisation, you do get a little bit extra. And there are some service incentives if you do certain things which aren't involved in actually seeing a patient face-to-face, but mainly fee-for-service. And we operate in an environment where there's universal government insurance, and we all pay for that with a levy on our income. The levy doesn't quite cover how much it costs, so some out of general revenue goes into it as well. And we talk a lot about whether it needs to go up or not. So when I see a patient, I have the right to charge whatever fee I think is fair enough. The government will rebate that patient a certain amount. It's $35.90, I think, now. That rebate has not kept pace with inflation. So that increasingly a problem in Australia is the out-of-pocket expense. In an area like mine where there aren't enough GPs, there's not much competition, so there's higher fees. In the city, where there's lots of competition, it's quite common to direct bill. That is, you accept the rebate only and the practice talks to the government directly about that. So there's a few different experiences. Now for Dennis, if he lives in my area, he may find that he hits a practice which doesn't direct bill at all, and he's asked to make a co-payment with every consultation. However, the vast majority of practitioners have absorbed the lack of the government's putting up in line with the cost of living, and will still direct bill for Dennis. And certainly in our practice, Dennis would be direct billed. We're supported by divisions, what's called divisions of general practice. These are meso-level organisations that have geographic spread and support all the practices in our region. So I'm the chair of our local division, and we support 66 general practices in our region. And so we're supported to implement new changes, or they help us with training nurses or practice managers, professional development, and also if there's a new initiative introduced, it's rolled out through the division, and that's all about to change. It's moving from being a general practice division to being a primary care organisation. So it's broadening to not be focused only on general practice, but to be focused on the whole primary care sector. That is a good thing, but we are running the risk of losing the buy-in from our GPs. And because they all work in their own businesses, they can just pull down the shutters and go off to work looking after people and not involve themselves in what's happening. So we're concerned about that, but we're working hard to make sure that doesn't happen. As described, we have the gatekeeper role, so for someone to see a specialist, they need to see me first. Dennis will get a referral from me if he needs it to see specialists. We spend about 9% of GDP on health, so that's up the good end, I guess. And we have good outcomes. We have this, for instance, the second longest life expectancy in the world, so that's not too bad. For certain populations, which we'll get to. For Dennis, It said, I think, in the scenario that he pays a neighbour to do things. That means he has a much higher pension than you get in Australia. If you get the pension in Australia, there's no way you're paying a neighbour to do anything. You're having trouble surviving. Pensions are poor, especially as a single person. If he had a partner with him and could convince someone that person was his partner, they could put their pensions together. And of course, electricity costs much the same. So yeah, he'd be better off if he had a partner. He might like to consider that. Yeah. Well, it's pretty warm where I live, actually. Yeah. So, but you can huddle together in the air conditioning. He doesn't need to formally register. We don't run lists. He just needs to make an appointment, and that could be a difficulty in my area. My books are closed and have been closed for the last 5 years. So because I just can't look after the people that I have on my list at the moment. We do have a doctor in our practice who his books are not closed because he started recently, so I would be recommending Dennis goes to see him. He just needs to make an appointment. However, Dennis has a problem in that he's going to have trouble coming into our rooms. And I'm afraid, like in the US, a home visit is punitive. I actually lose money compared to seeing him in the rooms. The amount, I think you got €9 extra for a home visit. It's not enough to cover the petrol and the extra time. However, I still do home visits most days because you have to. That's the commitment to the patient, isn't it? And a lot of GPs do, but a lot of GPs don't. I'm in a regional area. We have not good doctor-patient ratios. We don't have enough doctors anyway, GPs anyway, but there's also a maldistribution. So in urban areas it might be 1 doctor to 600 to 800 patients. In our area it might be 1 doctor to 2,000 patients. And that's uncomfortable, Joanne, for us. Very uncomfortable. There is opportunity for continuity. Dennis, if he wants to see that doctor, can keep seeing that doctor. If he doesn't like that doctor, he can vote with his feet and go elsewhere if someone else is willing to see him. And in fact, he could do it today. If he didn't like seeing me this morning, he could go down the road and see someone else this afternoon. He doesn't have to tell anybody. Now, that's got problems in that there's a lot of there can be discoordination, but it also has good things in that I know if I don't give him a good service, he's going to leave. It means, I think, that we have a very patient-focused or consumer-focused, in some good ways, some bad ways, system. The doctor will refer Dennis for services, and depending on the sophistication of the practice, there may be diabetic educators, there may be dietitians within the practice, there may be care pathways established where he would be plugged into a chronic disease plan for diabetes or his other issues, but for many practices we're not very sophisticated, and he may just get care when he turns up or rings up. So, it depends. There's a lot of variability in general practice, I think, in Australia. I hope there's some Australians here. If you've got a different view, please pipe up. There are specialist diabetes services. There are in our area. We'd have him plugged into that. There are community health services, but a unique part of our system is we have a federal government and we also have a number of state governments, and they like to pass the costs between them. So that state governments tend to run hospitals and the federal government tends to pay for general practice. So they'd much rather have the blood tests done in general practice because then it doesn't have to be done in the hospital. On the other hand, the federal government would rather have some things done in the hospital because then it doesn't have to be done in general practice. So that leads to all sorts of distortions. And community health is run by the state government, and so a bit like in Manchester, there's not a lot of communication with me where all the levers are federal government. It's unique to Australia. We're working on it. So with Dennis, it also matters, is he Aboriginal? I know he's got a Scottish accent, but in actual fact, you're Aboriginal if you identify as Aboriginal, and that's really important. Because of the way Australia has grown, many Aboriginal people don't look Aboriginal. So we really need to make sure someone identifies if they are Aboriginal. And if they are Aboriginal, there's all sorts of funding services to try and improve the care of Aboriginal people because they die 17 years earlier on average than non-Aboriginal people die. So we're working very hard. So if he's got that as part of his history and he's willing to identify, and a lot of Aboriginal people are not willing to identify because they've experienced negative experiences with regard to the state. If he's willing to identify, there are a lot of services that we can get for him, and coordination and drugs and so on. Is he a veteran? There's a whole different system for veterans. They can get other medications. Did he fight in a war, in other words? Does he have private insurance? A lot of elderly people scrimp and save to maintain their private insurance because if they need a knee replacement, it's considered elective, and they might need to wait a year to get it done, maybe more. Facilitators, direct billing is a big facilitator. It means that he can go and usually see a doctor and not pay anything. He can move doctor, and I think that's in some ways a facilitator, and that he's not happy, he can vote with his feet and see someone else. There are service incentive in payments for diabetes. If I do all of the measures for diabetes, I get $40, which isn't much, but it helps. An interesting thing in a fee-for-service environment is the government's invented a care planning fee-for-service item. So if I take the trouble to write a care plan with Dennis, and I certainly would, identifying his issues, his priorities, and listing them, listing his goals, and I would do that for each individual issue that he has, and then listing the interventions for each individual, and then listing the people involved. If I did that, I can claim an item number which is actually quite well remunerated. So I am encouraged to plan for Dennis, and that's great. What's more, if I then circulate it to the care team that I've identified for him, I can claim another item number. So it's a sort of a mixture of fee-for-service and not fee-for-service. And then that's quite remunerative. If I claim both those item numbers, then that triggers funding for Dennis. He can get a number of visits to podiatrists and dietitians and diabetic educators, which is a plus. It's not a lot. It's only 5 visits so far a year, which isn't really enough, but it's something that we could get for Dennis. So he'll get access to allied health. There's also state-based services, and there's also the divisions to provide some services. We have heavily computerised, so we've got reminder and recall systems that we can use for Dennis, and we have good affordable medication access. There will be a co-payment unless he spends, I think it's $1,300 in a year, then it becomes free. We have good hospital access. Everyone gets free hospital care. Dennis will get free hospital care in Australia in the public system, which has some delays. There are some challenges. Dennis's finances, I think, are the biggest challenge. It's going to be hard for him to afford to eat good food. There are home meal services which he could get. They are affordable. He may have trouble finding a doctor, as I've said. He's going to have trouble getting house calls, especially as a new patient. If you take on a new patient and they say, I'm going to need all house calls, oh, it's a deep breath to say, okay, I'll commit to you for the rest of your life to do house calls every month to you. It's a big commitment. Will he be able to get appointments? It's difficult to get appointments with me and others in our practice because we're too busy. The fee-for-service environment in Australia does drive activity. So there are some practices that do high throughput. Their model is high throughput. I guess they deal with 1 problem, 2 problems, maybe pretty well. Person's out the door pretty quick. That's how they make their money. The average time is actually 12 minutes for a consultation. And I guess that reflects a bit of altruism because that's not the best way to make money. But if he happens to light on a practice where it's high throughput, the sort of care he gets may be variable. But certainly the system drives high throughput. We don't have capitation. We have very little pay for quality, though we're looking at both of those things. A variable quality I've mentioned. Lack of integration. I don't know the community nurses. They don't work out of my practice. I ring them up and talk to them. I try to integrate with them, but it doesn't work that well. We're working on that. It's growing. Team-based care is nascent, and some practices do it very well. It's just beginning is what I mean. Some practices do it well, others don't do it so well. And we're in the middle of a major health reform process. The current government went through a major 2-year consultation, and they're changing everything. So that may affect Dennis's ability to access some elements of care as well. That's it.
Thank you very much indeed, Andrew. That's great. Are there any questions, points of clarification about the Australian system? At the back.
Yeah, you say that hospital care is free. Does that drive a lot of people to go to the hospital to avoid a co-payment to their GP?
There's a bit of that. Some people go to emergency for problems that should be managed in general practice, yes. Most people actually really like going to a GP. 83% of Australians will see a GP within a year, and on average they go 6 times. So we actually use GPs a lot.
6 times is high, and you care about half that.
Remember, we're driven by activity. So it's in a UK doctor's interests to provide good quality care with the right amounts of visits, whereas it's in our interest to get you back. If you don't have enough patients, it's in my interest to get you back in a month to get your blood pressure checked. Daft, but yeah. I think most people try to behave in an ethical way, but, you know. you get what you pay for.
Any other questions or points of clarification? Yeah.
12-minute consultations, is that what you said?
That's the average. So there's a lot longer. Industry standard would be to make a 15-minute booking, and most practices would provide a double booking if they thought it was a thing that needed it.
And chiropractic care, is that a big deal in Australia? Does the government pay for it?
Well, those 5 visits can be used for chiropractic care, and there's a bit of a controversy about that. There's a group calling to look at the evidence and say, is this something we want to put taxpayers' money into?
Great. Well, I'm going to invite all the speakers up onto the to the table at the front so that we can have a bit of a discussion. I'm going to get Dennis back so we don't forget who we're talking about today. And I think from my point of view, some of the, I mean, Maureen's keynote speech on Monday talked about, trying to focus on what matters to you rather than what matters. And I think one of the things that is of interest to me is the whole concept, this whole issue about social care. Because actually, when I talk to Dennis, he is unhappy with his life. He has lots of chronic diseases, so he doesn't feel great. He can't go out anymore. Occasionally, his carer that he pays for takes him to the pub, because that's actually where he'd like to go. He did go to a day centre for a while, but he hates it because he just sits. He just sits. He says, no, I just sit all day in a chair, and it hurts. I get pains. I don't like it. So he doesn't want to go. And I'm trying to encourage him to sort of even walk along the pathway outside his house just to get some exercise, to do something. So he's very difficult to manage, although his carer, the woman he pays a woman £100 a week, who's his neighbour, and she's become a friend. And the quality of care she gives him is brilliant. She pops in 6 times a week, 6 days a week, a few times a day, runs around doing everything, and it helps her because she's poor. She hasn't got any money too, so £100 for her is great too. So you get a lot of this informal care going on because actually our social care isn't always terribly good, and I think Robert brought that up. So I'm just going to put to the panel this whole concept of what matters to Dennis and this aspect of sort of social care and how that fits in, because we've been very medicalised and health-focused and the challenge in the system. So I'm just going to ask, I was interested by Andrew's about your care plans and the goals, because that's really interesting. I'm just going to ask the panel if you've got anything to say about social care and the challenges.
Does this work?
Yep. Yeah,
I think I mentioned social care in my presentation. Social care is probably about to be massively shaken up in the UK as the healthcare system is being. There's some very interesting discussions about what's going to happen, but it's seeming as though the direction of travel will be towards greater focus on re-abling people and then withdrawing. So there's going to be greater emphasis on helping people to be more independent, and then under-emphasising or giving less emphasis to ongoing care. And possibly that will come alongside, interestingly, a greater emphasis on community-derived solutions. So this asset-based approach to ask what we already have in our community, what communities could do for themselves. Certainly many people advising the government on social care reform would like that to come alongside this greater focus on re-ablement. Because I think if you have just one, people like Dennis could be left in quite a difficult situation. If you have both alongside, then actually solutions like being able to help your neighbour support you could get a lot more commonplace. And one of the mechanisms that's suggested to do that is to make greater use of giving personal budgets to people who have care needs. So a professional assessment will be made of someone's care needs, but that will be primarily to help determine how much money to give to the person themselves to buy whatever they would like. So if it was a taxi to take them to the pub, then actually they could use it for a taxi to take them to the pub rather than having some of the state-provided input to come and wash and dress you or do other things. So that there could be greater ceding of control to patients, but I think it's still slightly anyone's guess as to whether any of that will happen.
Okay. Thank you. Any other comments?
I would say we're just very much in the learning stages in the States. A lot of what I've spent my time here at the conference is just some of the citizen work and the community work, and how do we get some patient advisory community links started, because we don't have a good social network, so to speak.
I've got one other point. It was Nigel Edwards in his keynote presentation yesterday talked about the loss of the role of the generalist. And I was quite struck in the different presentations, because very much in the UK, GP general practice and Australia, that's really important to us. That we're proud to, we say, if people ask me what I specialise in, I say I specialise in being a generalist. And they look a bit confused for a while and have to work it out. And I'm very proud to say that, because it's great, because there aren't many generalists around, particularly in the hospital sector, and that's a real problem. But Joann, I was interested in the States that you said that you have all these diagnostic facilities, you're working with all these specialists. Does that stop you becoming a generalist, or using your generalism skills, or the incentives are to get more and more specialists involved in terms of the payments to your clinic?
I'm in a fortunate situation because those are all my partners. But truly in my group, primary care is pretty much subsidized. So if we stood alone, we wouldn't make money in our system. But because we're all working together and I'm their referral base, and they're seeing my patients, it works out very well. But I think in general in the United States, there's a lot of tension between specialty and primary care. In the academic settings, in the hospital settings, general medicine and primary care is often looked down upon, and people can't imagine when you're in training why you would ever join a primary care practice and do all that work and have all that scrutiny for so little money. And of course, when you're on the other side of it, you know the tremendous reward of taking care of a person like Dennis and really connecting with someone. But the patient side is very respectful and very much embraces often having a primary care provider. But generally, in the setting of the hospital itself or the academic setting, it isn't as valued. And certainly, I would say on the government level, we're not valuing primary care nearly as much as we need to do. That's we have to make some decisions around saving primary care, or that will be the forefront of our downfall in the next 2 decades.
Thank you. I'm David Moores from Edmonton, Alberta, and I want to thank Kate for being an organizer of this wonderful session. My question to France, to the United States, to England, and to Australia is, are there any complexity modifiers if you're dominated by fee-for-service? In Alberta, we are still dominated by fee-for-service, but many of us have other options, alternate payment plans and so on. So we have to shadow bill because that's how I'm paid. But we have complexity modifiers. Some doctors in Alberta will have a sign-up, only one problem per visit, and that's the perverse incentive of a conventional fee-for-service. But having access, if we deal with 3 or 4 conditions, including mental health conditions, I have access to several modifiers that will bump up a standard office visit from $33 to $78. Are there complexity modifiers in each of your respective countries, including the QOF? Will the QOF respect complexity for any home visit or any office visit?
I think that's what's so clever about the care planning item number, because it's really quite generous, like $35 for a standard consultation, direct billed, as opposed to $144 for a care plan. So to me, that's really driving addressing complexity and respecting it, and I think it's a very clever thing they've done. Funnily enough, a lot of GPs sort of complain about it and say, "Why are they paying us for that? It's what we do already." And I say, "Well, just be happy about it." So I think that's a good idea. I think that's one. There are some others, like if you use a nurse, you can add a little bit of money to what you bill. It used to be, they've just changed that. So yeah, there are some things like that. Do a mental health thing. There's a little bit. It used to be quite a good thing if you did a mental health assessment. They've just halved it without any consultation. Outraged all of general practice. So yeah, but there are still some.
So I think if you refer your patient to other specialists, we lost our approach of the patient, and the only one we can manage complexity, it's really GP, because they have all the information about environment, of a family, of community, and so on. If you refer to a specialist, you have a technical answer, but it's not enough. And we try also to develop in France patient therapeutic education to help Dennis, for example, to manage himself his disease. And I think it was the same process in your country. But it's sometimes difficult to implement patient therapeutic education in the free-for-service system because we don't have enough financial matters to develop this issue.
We have a few modifiers in the States, but it's nothing like that. So because of our coding system, and I won't go into a coding lecture, the basic office visit, which is 213, is just a straightforward problem that you take care of. Dennis, you know, we talk about having 214 days. Dennis is automatically a 214 when he walks in the door because he's got 2 or more chronic problems. Beyond that, unless you spend a lot of time with him, there isn't a modifier. And you know that it's like the home visit. Like the more time you spend, it's not paid that much more to not just see somebody else. So there's not too much more you can do unless you do a procedure to him. So yeah, or take off another toe. Yeah.
I think for us that my hope is all around outcomes. That if the current government can really deliver on its promise to move to incentivising outcomes and not processes or activity, then I think we could achieve a great deal. And particularly if the same locality-based commissioners are responsible for improving patient experience, patient outcomes, population outcomes, and cost, then I think we could achieve a great deal, because then you can do the things we're describing that need doing. As they are, there's a very odd mix of incentives, disincentives, and weirdness in our current system, which, yeah, we have 149 pay-per-performance indicators, and some of them are just a bit embarrassingly basic. I think if we can move to outcomes, then that the simplicity of that will enable us to handle those complexities, I think, a lot better. If.
I have a question. What would be the best? Oh, sorry.
Oh, thank you. I'm Nero Sriwarden from Lincoln, UK. Just a brief question about pay for performance, which you've touched on. For those countries which have pay for performance, would you recommend countries which don't have to have it? And for those who don't, would you like it? And could you explain why?
The problem is that the criteria are not really a guarantee of quality and safety of care. It's really, it's my own opinion, but I think that is really economic criteria to push a GP to prescribe generic or to have a good process for each chronic disease, but it's not really a way for quality. It's not the problem for public health insurance. The problem is not, it's only economic matters. And it's really a problem because the problem for French GP is it is necessary to pay again to have a good job.
I heard a talk from Martin Rowland about this, about funding of general practice. And I was attracted by what he said. He said there's basically 3 ways you can do it. You can do fee-for-service, you can do quality, or you can do capitation. They're the 3 ways we know. The way he analysed it, he said, what would a totally unethical person do in each of those systems? Fee-for-service, they'll see as many people they can in the shortest time they can. Capitation, they won't see anybody. Quality, they'll only attend to the issues that are measured, and everything else will be ignored. So his solution was, if you're dealing with a totally unethical person, is you need to dial up those various things to the right level for your culture. So you look at how you're going and think, okay, we're a bit unproductive, let's dial up fee for service. We're not really addressing, let's dial up quality. And I thought that's a sensible way to look at it.
I don't have to agree with Martin Runnan, but I will, because he's a friend and my PhD supervisor. I agree with that view, and the one thing I'd add in terms of the question, would I recommend it? The one graph I didn't show you, I showed you the graph showing that quality was improving for chronic diseases in Britain anyway. The one thing that seems undeniable is that our fee for performance system, imperfect though it is, has improved inequalities in Britain. One of the biggest sources of inequality in health performance and health outcome in the UK is where you live, and whether you live in a deprived area. And if you live in a deprived area, you're likely to get worse general practice, harder to access and less good. The QOF scheme has really quite impressively narrowed inequalities, and it's done it by bringing the worst up to the level of the average. Now, as Carol Harridan would say, that's only meant we've got everyone to be cream of the crap. But actually, at least the crap has got less prevalent by a very significant and very encouraging degree. So that's the one thing I'd say in favour of our current system. But I think, yeah, that three-pronged has to be it.
Got one last. Sorry.
Okay, I support your vision that the pay for performance should be in line with the best possible outcome for Dennis. But my question is, what is the best possible outcome for Dennis? How would you define that?
You got to ask him.
Yeah. Yeah, I would agree. I mean, I think that's the most important. That's the most important thing with the pay for performance too. Is I think it's one thing to know what the guidelines should be, but you really have to consider each individual patient. Now, for Dennis, better control is better for him. He'll stop losing toes, and probably his neuropathy, his pain will be better. So I think working to help him understand how the outcomes measures match what makes him feel better is important. But at some point, he's also 78, and you really need to have the conversation around, you know, you probably don't have a lot of years left. How do you want to spend them? And if it's at the pub, how do we get you comfortable enough to go to the pub and be okay with that? So I would agree with you. You really have to, you kind of have to juggle both. You have to look at your outcomes measures and work on it, but you have to keep the patient in the center.
I love the care planning process. When you ask a patient, you know, what's the most important health problem for you? And so often it's actually arthritis and the inability to walk to the end of the street. And I haven't considered that. To me, it's their diabetes or their terrible coronary artery disease or the fact they've got no feet. Well, no, that's not. No. But, you know, it's so asking them really is crucial. And then I have my agenda as well. So I love the care planning process, which brings the two agendas together.
And the nice thing is that I think when you have those conversations, you can make it a two-way thing. So I love when what happens is that then people are often surprised that you've asked what matters to them, and they often say, well, what do you think, doctor? And then you can address some of the things which actually people take for granted. One of the fascinating things, patients often take safety for granted. So when you ask them what's good care, it doesn't often occur to them to say, well, I don't want you to kill me inadvertently, because they take that for granted. I think the same is true for some extent of, well, I assume that you're doing all you can to stop me dying from a preventable complication. But actually, people often don't realise, you know, one of the reasons people don't take their medicine is they don't realise that aspirin tablet is helping to make it more likely they'll still be here next year. And so I love the fact that if you start by saying, well, what matters to you, then you can say, well, could I suggest some other things that probably matter to you, but you need to own for yourself. It's lovely.
Okay, well, thank you very much to all the presenters today, giving us an insight into their worlds.